So welcome everyone to Tuesday topic, mixed venous blood gas and metabolics. And I'm so grateful that you've joined today because there's a lot to talk about. We're going to really look at why it is that there's so much discussion about venous blood gases. Really important when we're thinking about that. We know that arterial blood gases help us to look at lung oxygenation, really important. Lung oxygenation, not tissue, lung oxygenation, and lung ventilation, and the acid-base status that is generally reflected both on the arterial and the venous side. But really important to understand the limitation of an arterial blood gas, which actually evaluates lung gas exchange and oxygen availability. So really critical to appreciate what that means to us when we're talking about evaluating patients. With a venous sample, the venous blood gas, and really that venous sample should be centrally or from the pulmonary artery measured. So it really needs to be a central venous blood gas. If you're doing it peripherally, it doesn't have quite as much rigorous meaning. It still be informative, but not quite as much rigor in the meaning. But the venous blood gas actually allows us to reflect on cellular respiration. So we see cellular respiration as an indicator in the PCCN, which we may not have time to talk about today. We'll see how things go, and our acid-base status. But also the VBG tells us about the adequacy of cardiac output as we reflect the oxygen in the venous compartment compared to the arterial compartment, and also as we compare venous CO2 to arterial CO2. And quite honestly, this really is an excellent endpoint for resuscitation. So if we have a central venous gas or a mixed venous gas, it's helpful to have other kinds of monitors, but this will really help us to evaluate, did the fluid I give the patient improve them on the venous side? Did the red blood cells I give the patient improve them on the venous side? Did the increase in respiration improve them on the venous side? So the venous side, I think overall, the way we should think about this is arterial side measures reflect pre-cell and venous side measures reflect post-cell. And the difference between the two is the amount of oxygen that the cells are using in order to maintain function. So really important to be thinking about this. And this is Barbara's simple division. Okay, we're going to divide our concerns into two. Do we have concerns with ventilation, with respiratory conditions? Ventilation and respiratory conditions. Sorry, whenever I let someone in, it always flips ahead. So ventilation, respiratory conditions really are most easily determined by looking at the arterial blood gas. Does my patient have lung hypoxia? Does my patient have respiratory failure? That's what we're going to look at when we look at the CO2. Is that patient a CO2 retainer, meaning the CO2 is high? Do I need to provide additional ventilation and ventilatory support? And is my treatment, my ventilation treatment, my respiratory treatment, are those working? I'm going to know that from the arterial sample. Now, we've done in these courses, we've talked a lot about arterial blood gases. We talked a lot about mechanical ventilation. This is the pinnacle, which is basically saying you need an arterial blood gas to truly evaluate what you're doing to and with and for the lungs. Those are your respiratory conditions. Arterial is helpful. But metabolic conditions are best evaluated with a venous sample. And remember, that really needs to be either central or mixed veins. So from a CVP line or from a pulmonary arterial catheter. This actually tells us very clearly about what's happening at the cell. Is the cell producing lactate and donating acid? So you have significant acidosis. Is the cell utilizing a lot of oxygen? Therefore, the SvO2 and the PVO2 are dropping, and that means you've got a patient at risk. And what is that CO2 production at the cell? And the base deficit, of course, but you can look at that in both arterial and venous. So we're really going to separate these two different levels of evaluation, thinking about why we use an arterial gas, why we use a venous gas, why we look at the two in consideration together, an ABG and a central VBG or a mixed VBG drawn at the same time. So we're comparing apples to apples. Okay, well, the reason we look at this is, of course, we appreciate and understand that tissue oxygenation is the most important issue in critical care. You've got hypotension, you add vasopressors, you're trying to assure perfusion and tissue oxygen delivery. You're using an inotrope, you're using packed cells. You're trying to ensure an appropriate oxygen delivery. You're using sedation and analgesia and temperature control. You're trying to decrease oxygen consumption. So it's really important to remember that tissue oxygenation is the single most important critical care issue. And no really critical patient's story is complete without the comparative analysis of an arterial blood gas and a central or mixed venous blood gas. So really important in terms of how we look at our patients, how we make treatment decisions, what's going to happen next. Now, the homeostatic physiologic components that are in balance in the human body are designed to maintain a balance between what is being delivered to the tissue and what is being consumed by the tissue. So we're going to call that oxygen delivery and oxygen consumption. Now, this is really critical because delivery of oxygen, combination of three things, we'll see it again, we'll talk more about it, three items, and they're in the order I'm saying them to you. So no matter what you see in publication or what you're thinking about your bedside, it's really important to put them into this order. Cardiac output, most important. Second most important is total hemoglobin, and least important is arterial saturation of the hemoglobin. As long as you're above 88%, that's probably going to be adequate. So again, most important, cardiac output. Second most important, hemoglobin. Least important, saturation of that hemoglobin. Those are the components of oxygen delivery. So remember, you might not be measuring cardiac output, but what you're able to do with the mixed venous or central venous gas is that when you look at the amount of oxygen that has been released from the hemoglobin, and it gets released when it flows through the capillaries to deliver oxygen to the cell, the amount of oxygen that gets released from the hemoglobin is going to be significant if you're not delivering enough or if the tissues are asking for too much. This is a really straightforward concept. Oxygen powered by your cardiac output bound to the hemoglobin presents a huge reserve of oxygen to be used by the cell. If I don't deliver enough, or if my cells are asking for too much, my hemoglobin will release oxygen, but I cannot see that in the arterial bed. The only place I can see it and make assumptions about what's occurring for my patient is in a central venous gas or a mixed venous blood gas. For the majority of you, it's going to be central venous. Typically, we use PA catheters most often in cardiology, sometimes with trauma-induced ARDS. So first and most important focus, because they're going to be very similar, will be the central venous blood gas, just drawn from your brown lumen on your triple lumen catheter. That's the distal port. You draw that gas, you send it off to the lab, you tell them it's venous, and they'll report that back. Very important is that hemoglobin will release oxygen at the blood flow level, at the capillary level. If cells need oxygen, and if they can get it. Your hemoglobin will consistently and persistently release, or what we call dissociate, oxygen, so it can be used by the cell. If it's bound to hemoglobin, hemoglobin is a big protein. If it's bound to hemoglobin, it can't be used. Has to be released from the hemoglobin to dissolve in the blood to be used at the cell. So this is such a straight, I really want to make it straightforward because it really is straightforward. SaO2 tells you about the lungs, not the cells. SvO2 tells you about the cells. And that's how we're going to use this information in the best possible way. So now I just say, okay, I have an ABG, I've got a PaO2 and SaO2. If I'm sophisticated, I'm really looking at gas and lung gas exchange. I take the patient's PO2 and divide it by the FiO2 in the decimal. That's called the PF ratio. So I want your PaO2 to be above 80. I want your SaO2 to be above 92%, the higher the better. And I want your PF ratio to be greater than 250. That tells me I've got good lung gas exchange, PaO2 greater than 80, SaO2 greater than 92%, higher the better, and a PF ratio, PaO2 divided by FiO2 in the decimal, of greater than 250. I feel really great now about your lungs, but the problem is if you stop there, you are not evaluating your patient. You need to know if the patient is hypoxic at the cellular level. So this is about my lungs. But the venous sample, and remember, best if it's central or mixed venous, because that we have research on and data on. Don't really know the meaning of peripheral oxygenation. So cellular oxygenation, really want to look at mixture of different organ output in the venous sample. We're going to look at the PVO2, of which I always need my patient to be above 37, and about 40 to 50 is normal. The SvO2, which I want to see above 60, and the PVCO2, which I would like to see between 40 and 50 and no higher. So really quite strategically, I'm going to separate lung gas exchange and cell gas exchange. Lung gas exchange, I'm going to use the letters A, PaO2, SaO2, PaO2 divided by FiO2, or the P to F ratio. For cell gas exchange, I'm going to look at PVO2, I'm going to look at SvO2, and I'm going to look at PVCO2. Now, we might not get to CO2 today, but we'll do it next time because it's so incredible and it's really, really meaningful when we're talking about cellular respiration. Okay, and then, of course, the very basics of your bicarb, that's your total serum CO2 on your chemistry panel. For some folks on their blood gases, they get a bicarb. For us here at Grady, we get a base deficit. Bicarb and base, actually, when those are up, metabolic acid is down. When those are down, metabolic acid is up. That's the main thing you need to remember. It's important to understand it more in a more in-depth way, but for our purposes today, when bicarb and base are down, metabolic acid, which is hydrogen ion, is up. Great, that's it. So we look at base, we look at bicarb, we look at pH, and we're going to look at PV and PaCO2. Now, in either case, PVCO2 or PaCO2, you're looking at CO2 transport in the blood, which is a reflection of cellular respiration and lung clearance. So really important when we're talking about that. So let's just compare, starting with your pH, 7.35 to 7.45 arterial, that's the normal range. And venous, it's only 0.03 different, 7.32 to 7.42. So this is arterial, this is venous. Oxygen saturation in the arterial bed, usually higher than 90%. We'd like you around 92%. We get worried when you're at 88%. And in the venous compartment, we'd like to see it around 70 or greater. So there's a big difference between these two, not such a big difference here, right? And then we look at PO2. PaO2, typically around 110, 100 or so, right? And venous oxygen, because the difference between arterial and venous is what the cells used. So venous oxygen typically is much lower. Less than 36 means your patient's in shock. That's one thing you have to know. Less than 36, your patient's in shock. Okay, so if I have a PVO2 of less than 36, typically my SvO2 will be less than 60%. That's telling you that you've got a patient that is taking extraordinary amounts of oxygen because A, you're not delivering enough, or B, the tissues are asking for too much. And then we look at PCO2. So this is arterial and this is venous. Okay, so the three major things that are difference between arterial and venous samples: PO2, O2 sat, and PCO2. These are pretty big differences between the two. pH, not much difference, 0.03. Base, almost exactly the same between arterial and venous. So really important to appreciate when you're looking at a venous sample, your eyes will immediately go to PVO2, SvO2, and PVCO2. Everything you want to know about the cells are going to be answered by those numbers. Okay, so really, really important to remember that sometimes, like an emergency room, you might not have an A line. It's really easy to get a venous sample. Usually it's a peripheral sample, which makes it a little less meaningful, but very important to basically say, if all I can get is peripheral, I can actually convert it to ABG. That's what this table is. No one's asking you to memorize this, but I want you to see that it's a very similar property. So you convert VBG to ABG peripherally by adding this, subtracting that, subtracting that. Okay. Now, I want to remind you of what I said before. When I look at an arterial blood gas, that is telling me about delivery side dynamics. And the components of oxygen delivery, number one, most important, what the patient manipulates himself is cardiac output. Cardiac output is heart rate times stroke volume. Patient can manipulate his heart rate significantly, can minorly manipulate his stroke volume, but you are going to majorly manipulate stroke volume by giving the patient volume or by giving the patient inotrope. Your goal is to increase the stroke volume and therefore improve the cardiac output. Number two is the total hemoglobin, because hemoglobin's sole purpose in the human body, well, it has two purposes: to carry oxygen to the cells and to carry carbon dioxide back to the lungs. That's the only purpose, is to carry those gases. Oxygen to the cell, carbon dioxide to the lung. That's the only purpose of hemoglobin. That's why we care about it. And least important is the saturation of hemoglobin. So when my patient has inadequate delivery, the first thing he's going to do is increase his heart rate. If he can, he'll increase his stroke volume, but usually he needs you to do that by giving volume or by giving an inotrope. And as you increase the stroke volume, his heart rate can come down. But our patients in general, when you see a sustained tachycardia, you need to interpret that as a mechanism to increase oxygen delivery. And now it's all about you being an investigator, trying to discover what the problem is. Most patients will compensate when they don't have enough delivery or when the cells are using more oxygen by increasing the heart rate, and if they can, by increasing the stroke volume. They cannot immediately increase their total hemoglobin. That's a really slow process. So you can affect that by giving packed cells, but the patient isn't going to all of a sudden make more hemoglobin to carry oxygen. That's going to take time. And they may already have some lung dysfunction, so they may not be able to increase their SAT. So patients are relying on you to look at that cardiac output and increase the cardiac output in order to deliver more oxygen to the cell. So now I'm going to show this slide a couple of times and maybe in a couple of different ways. So anything that is after the lung and before the cell, I'm going to call that post-lung, pre-cell. Arterial saturation, post-lung, pre-cell. I can have a great SAT and be dying, okay? Dissolved oxygen, PaO2, post-lung, pre-cell. Now, the purpose of our blood flow is to exquisitely transfer into the capillaries. Capillaries surround the cells, and as long as they are close, cells should be able to extract or utilize or consume the available oxygen. And as soon as that PaO2 drops, we're going to release oxygen from our hemoglobin. That's called dissociation. So your hemoglobin releases oxygen more and more and more rapidly to keep up with the cellular demand. But the caveat is you got to be flowing blood through the capillaries, and the capillaries have to be close to the cell. So think about two things that happen in your ICU and in your acute care settings where this does not occur. Number one, when I vasoconstrict you, I'm going to limit the way your blood flows into the capillaries, which means I might have oxygen on the arterial side, but it may not be adequate because it's not flowing appropriately because you're vasoconstricted. And the other is, remember that the cells need to be completely surrounded by capillaries, but when fluid gets in between, your patient has interstitial edema, they have destruction of the endothelial border of the vessel, and fluid leaks out, or the hydrostatic pressure in the vessel is high and fluid creeps out. That fluid separates the capillaries from the cell, and the cells can no longer get their oxygen. And the only way you're going to know that, is if you look at it in the venous bed. You can't evaluate this in the arterial bed. Anybody who thinks they can is wrong. They're just wrong. You have to be able to look at it in the venous compartment. So remember, I talked about central or mixed vein. Central venous is measured from the right atrium or from the central line. Mixed venous is measured from the tip of the PA distal port that's in the PA of the pulmonary arterial catheter. So let's really focus here on the right atria or the central vein. SvO2, central venous oxygen, normally 65 to 85%. That is post-cell, pre-lung. So this is reflecting what your cells have used. PVO2, 40 to 50, that's a good one. Just remember it as 40 to 50, that'll make it easier for you. Okay, that's what is remaining in the dissolved state after the hemoglobin has released oxygen to dissolve into the blood, and the tissues have used that oxygen. So when the tissues are demanding more oxygen, your PVO2 drops, your hemoglobin releases oxygen, and your SvO2 drops. Pretty straightforward. It's basically just an ATM. When we can use our ATM, we take money out of the bank, our bank balance drops. When we can use our ATM. But your magnetic strip was exposed to your phone, you can't get money out of the bank. So your reserve, your bank balance, like your SvO2, might be normal, but your cells are hypoxic. So really important to focus on this and to have a good grasp, a good understanding of this, because it is incredibly meaningful. Venous oxygen saturation can be measured intermittently or continuously from the central vein, the brown lumen on a central catheter, or the mixed vein from the PA distal lumen by drawing a blood sample. And that's how most of us do it. Most of us draw a blood sample. Now, the problem with just drawing the blood sample is the best thing you've got, do it, do it, do it, do it. But it's like taking, let's say you have only one grandchild, never going to have another. You want to measure every minute. And when they walk, taking a photo doesn't give you the whole picture, right? You want a video. Well, that's what SvO2 is. Continuous is a video. It's a continuous evaluation of what's happening to the patient. So a cautionary tale, because the majority of us are drawing intermittent venous gases, that's totally beautiful. But for at least 5 minutes before you draw that venous sample, do not move the patient, don't suction the patient, don't stimulate them. All those things, movement, suctioning, stimulation, will cause SvO2 to drop. And patients will rebound pretty quickly, but if you only took one moment in time, You don't know that. So really important, if you want to have integrity and value in your measurement, don't stimulate, don't suction, don't turn. So what that means is when you bundle all your care, you're going to bathe the patient, you're going to turn the patient, you're going to change the bed, and then you draw a venous sample. That's not going to really reflect what's happening for your patient because you just did a lot of physical activity. So you should always set up the drawing of a venous sample at a time when your patient has had 5 minutes of complete physiologic rest. Physiologic rest. Okay. Then that value is going to be much more meaningful. Now remember, SvO2 is what we call mixed vein. It means all the veins drop their blood in the right atria, mixed in the right ventricle, mixed up into the pulmonary artery, but it is only venous blood, but it's representative of every single cell and organ. Central venous oxygen measurements are not reflective of every single cell and organ. It really reflects blood that returns from the cerebral environment, the upper extremities, because it's measured typically in the superior vena cava. So it doesn't necessarily reflect the total body use of oxygen, but it's still going to be meaningful, and it still tends to trend in the same direction. So we're just going to say we'd like to see our patients at 65 to 70. Anything lower than 65 makes us concerned that the hemoglobin is having to release oxygen so it can be used by the cells. The difference between the two is SvO2 central vein, and it is regional. SvO2 is global. It reflects all the organs and the cells. And our generalized target for either one is that we'd like you to be at around 70%. What that means is then when you get turned, when you get suctioned, you have a reservoir of oxygen that you can borrow from without infarcting your cells. Okay. So now I want to talk about the second compensation, which tends to be more difficult for folks, but it's really straightforward. All you're really doing when you're talking about SvO2 is you are reflecting what the cells are consuming, and you're measuring that in the central or mixed venous bed, okay? So the amount of oxygen required by your cells changes every second, and it all depends on what's happening. So basically, to remind yourself, when your demand goes down or your consumption goes up, you're not going to die because you've got a big reserve of oxygen, right? We target it to be around 70%. So now, if my delivery has gone down or my demand has gone up, I've got a fever, I'm shivering, I've got seizures, you're stimulating me, you're turning me, you're bathing me, my wife is yelling at me, whatever, my husband is yelling at me, whatever. Your hemoglobin is going to release oxygen more rapidly because you need it at the cell and your delivery didn't accommodate for that, okay? So that's really important. Hemoglobin releases oxygen when cells need it and cells can get it. And that means your SvO2 drops because you're using more oxygen at the cell. Now, in one way, this is really good because it means the cells are able to consume the oxygen. But in another way, it means you're completely set up for profound ischemia infarction at the cellular level. So you can't allow it to persist. You have to reduce the demand and increase the delivery. That's always the answer. Increase delivery and reduce demand. So whenever SvO2 has dropped, you're going to increase delivery and decrease demand. That's what you have to do. This is your second compensatory mechanism, which is hemoglobin will release more oxygen. That's called a shift to the right. Release, 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 to the right, to the right, to the right, release. Off the hemoglobin, dissolved in the blood so it can be used by the cell. Can't use oxygen when it's bound to hemoglobin. It's got to be dissolved in the cell. And if your SvO2 is higher than normal, higher than 70%, you actually have what we then call a shift to the left. Hemoglobin has latched on to oxygen. Now that happens in two cases. That means your SvO2 is higher than you anticipated. SvO2 is higher than you anticipated. because cells don't need it, or cells need it, but they can't get it. And the two most common reasons that cells need it, but they can't get it: severe vasoconstriction employed by us, and a failure of the lining of the vessel, which occurs in shock, and particularly in septic shock. Interstitial edema separating the capillary from the cell can't get the oxygen. So the oxygen stays bound to the hemoglobin, but the cells are slowly or rapidly dying. This is incredibly important because when you see this, all your therapy is designed towards minimizing this damage. If you're not looking at this, and quite honestly, I don't think most people look at it very succinctly or utilize it to drive their intervention plans, but it is such a meaningful tool. Okay, so some of our physicians don't like it, others adore it. Some say, I love it, but it's not being measured correctly. Okay, we can change that. We can measure it correctly. We can report it appropriately. We can bind the number of our SvO2 into a bundle that actually says what the problem is. Do you have a base deficit? Do you have elevated lactate? Is your bicarb low? And your SvO2, what's that? If it's high, your cells can't use it. And if it's low, you need to supply more. It's pretty straightforward, but we've got to really know how to utilize the tool. So sometimes, like in my own practice, I will often hear nurses say, well, we collect all that data, but the docs don't do anything. Sometimes the docs don't do anything because they're not really sure what it means. You know, if you spend an hour with me here talking about SvO2, that's 59 minutes more than your physicians get in medical school. They don't get much exposure to this. So whatever exposure they get comes from their attending on rounds. And if their attending on rounds is a recent graduate in the last 10 years, they didn't get a lot of information on this either. The people who really get information on this are pulmonary critical care doctors. But really outside of that, most of our physicians aren't really well educated. That is not a diss. It's just the reality of education today. So really, really important that you know. So now we go back to that picture and we just remember that the difference between what went out in the artery, arterial set, and what returned in the central vein, venous set, that's how much oxygen your cells used. So if you look at a normal difference, the normal difference is 20 to 30% of oxygen gets used by the cell. That's normal. If your cells need more and they can get it, that gap is going to get wide. That difference is going to be bigger because the cells are using more oxygen. If they need it and they can get it. And remember what that issue is. You're not delivering enough or the cells are demanding too much. That's it. There's no hidden message. You're not delivering enough because you don't have an adequate cardiac output or you don't have an adequate hemoglobin. Okay, that's pretty straightforward. That's really meaningful. So always remind yourself central venous oxygen is post-cell oxygen remaining bound in the hemoglobin because your cells didn't need it, or because they did need it and they took it, or because they did need it, but they couldn't get it. So you have 3 levels of SvO2. When SvO2 is low, your cells need it and they took it. When your SvO2 is normal to high, your cells didn't need it, or your cells needed it, but they couldn't get it. That's really important. 3 levels. 3 levels. Cells need it and they got it. SvO2 is low. Do not allow patients to stay there. Increase delivery, decrease demand. Cells don't need it. Maybe you've given too much volume, too many red cells, you're on inotrope, maybe your patient doesn't need it anymore. Their SvO2 is high, but they don't have metabolic acidosis. Okay, back off on the treatment. You don't need it. You don't need to be so aggressive. But the cell that needs the oxygen but can't get it, you're going to have a normal to high SvO2 with a profound metabolic acidosis, which means without you running interference this patient's cells are going to die by the millions. We have to intervene. Okay. So again, just reminding you about PVO2, SvO2, or ScVO2, either case, fine. What the meaning of this is for us when we are at the bedside. Okay. So I always like to remind everyone that the primary role of hemoglobin is to carry oxygen. It's carried on the binding sites, each saturated hemoglobin. So when you look at percent, you look at percent of hemoglobin saturated, 99% of the hemoglobin are saturated, you've got an SaO2 of 99%. That means almost all your hemoglobin are carrying an abundant amount of oxygen. At 88% saturation, well, 12% of your hemoglobin aren't carrying oxygen, and that could really be an issue for your patient. That's why you look at O2 sats to say, what can I do to the lung to improve hemoglobin saturation? And again, as long as you're above 88% in general, I'm pretty okay with that. It's when you go below 88% that I'm going to be worried about your saturation, that I'm going to start to ask for someone, myself or someone else, to fiddle with your ventilator to improve your saturation. Okay? Really, really important. So just remember, bound oxygen in the arterial bed must dissociate into the plasma, which dissolves it, so it can be used by the cell. So it comes from the hemoglobin into the plasma to get to the cell. Cell needs it, cell can get it. You're going to rapidly reduce the saturation, and you're going to see that over here in the SvO2 or ScVO2. So when that drops, what that's telling you is you are releasing, shifting to the right, releasing the oxygen to dissolve in the blood to be used by the cell. Yay, this is great news. Stop it right now. I'm thrilled that you're doing it because it means your cells are able to use oxygen. But I want you to stop it. I want to control the demand, sedation, analgesia, paralytics, and increase delivery, stroke volume, and hemoglobin. So straightforward. It's a really simple strategy. Now, this is an equation that sometimes especially surgeons talk about. They talk about content of oxygen in the arterial bed. That takes the amount of oxygen in mils times the number of hemoglobin times the percent saturation. That's content of arterial oxygen. Content of venous oxygen just doesn't use the SaO2, it uses the SvO2. I'm sorry, that says SaO2. Let me fix that right now. So just in case somebody fell asleep and now they're going to look at that, they'll know that I'm saying the right thing here. SvO2. Okay. So I made this simple cartoon. I think it's really a simple cartoon. Maintaining your cell's oxygen consumption is a balance between delivery and dissociation. First response is always to increase delivery by cardiac output, heart rate times stroke volume. Remember, when you go into a room with a patient with persistent tachycardia, they're trying to deliver more cardiac output. Pay attention. Hemoglobin second, saturation third, and this is arterial side dynamics. When we go over to the venous side dynamics, all we're doing is looking at how rapidly or aggressively the hemoglobin is dissociating, and we measure that with SvO2 or ScVO2, and we correlate that to the base deficit or serum bicarb. Remember, if they're down, metabolic acid is up, and we can also use lactate. Pretty straightforward, relatively simple. So these are the kinds of visuals you'll see in a textbook on just about for any test you're ever going to take. There's a discussion about the right shift, which means release from the hemoglobin, dissolved in the blood, and used by the cell. Tissues need it, and they can use it. Typically, what you see is the presence of acidosis. Tissues need it. Acidosis gets better if they can dissociate oxygen. So you look at it with the hydrogen ion, and you're reflecting that with the base and the bicarb. There's serum CO2, their venous CO2. And we know that patients who have a high temperature or who have an absence of an enzyme that's a biphosphate or diphosphoglycerate. And by the way, the only reason I put this here, really there's two. They always ask this question on your CCRN and PCCN exam, also on your CEN exam. And that is that the enzyme, this enzyme is used to release oxygen from hemoglobin, and it is not present in bank blood. So when you do an MTP, you've got a trauma patient, you've given them 8, 10, 12, 30 units of packed cells. They're going to be able to carry oxygen, but they won't be able to release it, and they'll have really severe metabolic acidosis. That's why in most MTP protocols, you now start with whole blood and then go to packed cells, because in whole blood, you'll have this enzyme that will help you release oxygen from hemoglobin. And really, for every 4 to 6 units of packed cells, you should get another unit of whole blood. That's why most MTP protocols reflect that in today's world. Whole blood gives you, obviously gives you all your components, but it also gives you that enzyme that releases oxygen from hemoglobin. Left shift is meaning that your tissues don't need it, or they do need it, but they can't use it. So they don't need it when they don't have metabolic acidosis or respiratory acidosis, when their temperature is normal, or when they have normal 2,3 BPG or DPG, either one, di or bi is fine. Okay. But cells that need it but can't use it, they're going to have metabolic acidosis. They're going to probably have respiratory acidosis. They may have a high temperature or a low temperature, but they can't use it. And the most common cause for this is disruption of the lining of the vessel. That's called the glycocalyx. That's destroyed in shock states. So fluid just leaks out, creeps out into the interstitium, separates the capillary from the cell. So by the way, the main thing you need to do for those patients is get them on CRT and help relieve some of their fluid, their hydrostatic fluid that's caused that problem. Okay, so always really important to say, I'm going to correlate the base deficit or the bicarb. So remember, bicarb less than 22 is reflecting an increase in metabolic acid. And the more base that you have in deficit, the more metabolic acid you have. So there's always 4 big questions for the majority of us at the bedside. We're not talking about metformin toxicity or other kinds of things. What might happen if you're HIV positive? Those are more specific issues. But for us in critical care, the first 4 questions when we have a base deficit is my patient ketotic? That's hyperglycemia and ketosis. Do they have acute kidney injury? Looking at their serum creatinine and their correlation of glomerular filtration rate, that comes back on your lab. Do they have high chloride? Chloride binds to the metabolic acid. Cl marries H, that makes HCl, a strong acid. So that's really important. And if you don't have any one of these 3, basically you're just looking at the patient's glucose, you're looking at their creatinine, you're looking at their chloride, and if none of these is abnormal, you're going to assume it's lactic acidosis. Okay. So now I correlate my base deficit to my level of serum of central venous oxygen, SvO2. Okay, serum central venous oxygen saturation. Shift to the right means hemoglobin is releasing aggressively and rapidly. The SvO2 number will be less, typically less than 65 and usually less than 60. So your saturation in your venous bed has gone down. You get that from your venous blood gas. It means your cardiac output is poor relative to the tissue demand. You might have a cardiac output that's twice normal, but if you have profound acidosis at the cellular level, cardiac output is poor relative to that demand. The demand is high or the content of oxygen is low. So what are you going to do? You're going to manipulate the stroke volume. You're going to sedate and control the tissues, and you're going to evaluate if the patient needs hemoglobin. That's the answer. Volume, inotrope, hemoglobin, sedation, analgesia, and if necessary, paralysis. It's straightforward. Okay. Now, the problem is that when you do shift to the right, your cells are using it. Increased consumption of oxygen, it puts your cells at risk for cellular destruction. That's why you cannot allow patients, to have SvO2s or SvO2s that are less than 60%. They are now in the ischemia window and they can infarct their cells. Okay, so remember, hemoglobin has released the oxygen to dissolve in the blood so it can be used at the cell. Whenever SvO2 is low, you always need to be concerned. You want to increase delivery and decrease demand. Okay, When delivery is adequate and the cells can utilize oxygen, that's called a shift to the left. Hemoglobin latches onto the oxygen. You don't need to release it. Demand is probably normal. Cardiac output is adequate. Content of oxygen, that's the amount of hemoglobin carrying oxygen, is adequate. Okay, so you latched on to hemoglobin. Oxygen has latched onto hemoglobin. We're not using that much oxygen. Now, that's really important to actually correlate that SvO2 number, which might be 70, 75, 80, 85. You need to be sure that your patient doesn't have metabolic acidosis. None of this is ever meaningful without a correlate of metabolic acidosis, because that's what really defines the adequacy of cellular use of oxygen. So always want to do a lactic acid check, always want to do a metabolic acid check. Don't just write down an SvO2 number. So you're at the bedside, you're monitoring SvO2 with the PA catheter, it's 65%, you're writing down 65%, and you're asking yourself, why am I having to go up on the vasopressors? And then you send a blood gas and you discover the patient's profoundly acidotic. What that SvO2 has told you is your patient cannot use the oxygen. They're not using it. And the most likely reason is because it isn't flowing into the capillaries and there's too much distance between the cell and the capillary for your patient to use oxygen. Shift to the left. When you look at SvO2 or ScVO2, it looks adequate, but your patient's on acidosis. You put them on vasopressors and you're titrating up, they require CRT. Things are not okay. Don't be charting an SvO2 and then telling people he has a normal SvO2. If you got metabolic acidosis, your SvO2 should be down because you should be releasing oxygen. So that's an abnormal shift to the left. That means a normal or elevated SvO2 in the face of metabolic acidosis is always, always abnormal. So SvO2 tells you about the state of oxygen dissociation. Base and bicarb correlate whether or not that oxygen is adequate. That's what's critically and profoundly important. So never one of these being complete. You need them all. You need SvO2 or ScVO2. You need to correlate that with the base. Your lactate may be up or it may not be up. Patients clear lactate and they can clear it really rapidly. So lactate is not a great indicator. Your best indicator is your base deficit and your serum bicarb. SvO2 is down, bicarb is down, your patient has metabolic acid, they're behaving as they should, they're using oxygen, increased delivery, decreased demand. Your SvO2 is normal to high, but you have a severe base deficit and their lactate may be elevated, they're hypoperfused and they are not able to use the oxygen. And in general, the problem is too much fluid creating hydrostatic correlation, pushing fluid into the interstitium, and too much vasopressor, limiting blood flow into the capillaries. That is really the important concept in SvO2 and metabolics. Metabolics are the hydrogen ion. SvO2 is the available oxygen. If I'm acidotic, I should always be releasing oxygen. If I'm acidotic with the normal SvO2, I'm not releasing oxygen, I've got a bigger problem. I've got to try to figure out what to do. And basically, here's what you do. You always want to increase cardiac output and index. You give volume, inotrope, or your patient might need an Impella or ECMO. And don't wait too long. Now, we might not want to give them volume because they've gained 60 kilograms in our ICU. They cannot use oxygen. So now I'm going to think about diuresis and inotrope. I'm going to think about CRT. I'm going to think about an Impella, and I'm going to think about ECMO. And honestly, if you want to really save that patient's life, go directly to ECMO. Stop wasting time fooling around. I don't care if physicians feel like they have to own patients and they never call for ECMO till the end. That just can't happen. We've got to advocate. We've got a patient with a base deficit and a normal SvO2 who's gained weight. They are profoundly hypoxic, and we're using an extraordinary amount of vasopressors trying to recruit their blood vessels. You need to be talking about ECMO sooner rather than later. Never hurts you to say, is this patient a candidate for ECMO? Usually what our docs will say, Oh, maybe we're going to see if they get better over the next 24 or 36 hours. But by the time we get to 24 or 36 hours, they're no longer a candidate for ECMO because they are so now cellular and organ dysfunctional. So we really have to advocate early. Okay. The other thing is you can increase O2 content. And the only way you're really going to do this by giving PAC cells. 2 units of PAC cells overwhelms your 2,3 DPG or BPG. That means that you never want to give more than 2 units of PAC cells without considering whole blood in order to give them the enzyme that releases oxygen from the hemoglobin. And then this is the really great one. Control their fever. This is oxyconsumption. Control their fever. Make sure they're not working hard to breathe. Make sure the ventilator is supporting the patient and that the patient is not combative and dysynchronous with the ventilator. Get your therapist, put together a plan. Make sure you're adequately sedated and you have adequate analgesia. You might have to consider paralyzing the patient when you have such significant demand because the cells are so hypermetabolic. That is a time, if I cannot control you with sedation and analgesia, I'm going to think about paralytics. And of course, try to control seizures, try to control shivering. So of course, with seizures, we're going to get a neuroconsult, we're going to put patients on Keppra and other agents to control their seizures. Every time they seize, they're going to use a huge amount of oxygen. Every time they shiver, they're going to use a huge amount of oxygen. Remember, shivering, no matter what the cause is, shivering is best managed with Tylenol, Buspar, and warming techniques on the periphery with a warming blanket, not with an Arctic sun. That's a central warm, but a peripheral warm. You're going to best control shivering with counter-warming techniques. The idea and the really important perspective is to be able to apply this when you're looking at a patient. So we've got a 78-year-old woman, history of hypertension, AFib, diabetes mellitus, type 2, and COPD, and she presents to ECC with severe abdominal pain. She has very tender abdomen and wheezes with the following vital signs. She's tachycardic, 110. Now, you might not think that's quite tachycardic, but she's 78. That's pretty tachycardic for her. Her respiratory rate is 22. It's mildly tachypnic. Always assume those two things together or just tachypnea alone, that these are compensatory for tissue hypoxia. Her temp is 37, so we're not that worried about that. Her blood pressure, 105/70. Gee, that looks good. But her central venous oxygen is 55%, which means it's low. Delivery is not adequate. Demand is too high. Then on her venous sample, we run it, and it's a central venous sample. So we got a SAT, and we send it off to the blood gas lab, and her central venous sample, pH 7.2, PVCO2 29, PVO2 33. Your patient is profoundly hypoxic, and she has very severe metabolic acidosis, and she has hyperlactatemia. The only thing that's going to save this patient is immediately addressing the fact that she can use her oxygen, she's not delivering enough, and she's demanding too much. It's really all up to you. Actually advocating and bringing the science together in terms of the way you're communicating with your colleagues and your providers so that you are sure they are getting the whole picture. Just reporting SvO2 is not good enough. You've got to look at it in the context of whether or not the cells are adequately maintained. In the presence of acidosis, you have to consider that the cells are not adequately maintained no matter what the SAT is. And you're going to increase delivery. That's cardiac output, primarily stroke volume. You might increase the content by giving 1 to 2 units of PAC cells, and you're going to decrease demand. Control shivers, control seizures, control pain, sedation, and if that doesn't work, consider paralytic. Thank you very, very much for joining today. And I so appreciate you and appreciate all the work you do at the bedside. Hopefully, I'll see you tomorrow for part 2 of the PA catheter and Wednesday for heart failure